Sarah, I think Zoom noticed that the case was going to be so good that collapsed. So, but great that you're back. So you were mentioning painful joints, especially on the knees as the chief concern. That's a great start. Definitely a lot to talk about with that HPI. So I think Kirtan was mentioning his approach. Maybe you could share with us what you're thinking, Kirtan.
Yes, sure. So one of the things that I have learned from our schemas and the Rabi and Reza is that we have to understand what are the things which can kill the patient so fast. So the fact that we have painful joints, the first thing I want to look for is, does the patient have any evidence of systemic infection? Does the patient has fever, any joint redness, erythema, pain there? Because if that is there, then we can prioritize the septic arthritis. And by thinking about septic arthritis, we also have to think about the complications of arthritis. Let's say patient has developed abscess in the nearby structures. What if the patient has sepsis or endocarditis, which is causing seeding of the joints? So these are some of the priorities. And once we have ruled out these causes, we can move on to the another aspect, that do we need to tap this joint? Because tapping the joint is extremely important, because the analysis of the synovial fluid can give us an idea that what kind of infection we are dealing with. And if it is not infection, what are the other conditions which can mimic infection? So things like crystallopathy. So let's say gout is there, calcium pyrophosphate crystal deposition is there. Both of them can present as erythema and painful joints, and it can mimic infections. So we have to do the synovial fluid analysis too. Once we have ruled out these two common things, crystallopathy and infections, we can move to other possibilities like complement mediated disorders or immune complex mediated disorders. So what if the patient is a young female and we are dealing with rheumatologic conditions? So things like systemic lupus erythematosus, sarcoidosis, systemic sclerosis, all sorts of vasculitis. And what if the patient is, let's say, on some sort of drugs? Then we know that drugs can cause serum sickness-like reaction, which can also present as painful joints. What if this patient is an old patient and we are just dealing with simply osteoarthritis, things like that? What if the patient is a middle-aged female and we are dealing with rheumatoid arthritis? So there are various ways in which we can approach the painful joints, and the key will be the time course and the distribution of joints. So right now we are dealing with the knees, so that kind of limits our differential. But as we get the HPI, we can gather more clues that whether we are dealing with infection, inflammation, or something more weirder autoimmune causes.
Love it, Kirtan, prioritizing things that could kill the patient and then giving us a systematic approach through infectious versus non-infectious etiologies. Ramla, I see you were commenting on some questions to ask with this presentation, and you always have something great to say on the chat. So could you maybe share with us what you're thinking?
Yeah, sure. Are you able to hear me?
Yeah, we hear you perfectly.
Yeah, sorry, my video is not on because I'm multitasking right now, but just listening to the discussion. Of course, I'm a family medicine physician now. I just completed residency in Minnesota. So whenever, I see that this patient is an inpatient, so that sort of gets me wondering, okay, what else is happening? But, if I saw this patient as an outpatient, common questions I usually ask the patient is, okay, for how long have you had these joint pains? Are they in how many joints? Because that's very important, because that kind of lets you know where I need to think about with my differentials. Has the joint pain migrated, and in what direction? Is it proximal distal or distal to proximal kind of thing? The symmetry, prior history. Very important to ask those questions about joint pains. And then, yes, you go into, what the previous speaker has said about, your worst case scenario, I always try to say, okay, what is the big, bad, and ugly that could kill this patient? And what has the most mortality compared to morbidity? And those are your septic arthritis. So you really need to rule that out. And then that's where you look for the erythema and the fever and whatnot. But considering this patient is an inpatient, so that gets me worried. Could this be a manifestation of a systemic illness, inflammatory process happening, autoimmune? But definitely, knowing the age of the patient, sometimes even the gender can be very helpful as to, okay, where do I pivot next with how to think about this? So those are my thoughts.
Great. Love the questions that you share with us, and also thinking who is this patient, and also making the emphasis, as well as Kirtan, that septic arthritis is one thing that we don't want to miss on a patient that comes with joints or painful joints. So great. I think that's a great start. Maybe, Ravi, I don't know if you could reflect. I've heard you reflected on painful joints before, and I think you could contribute a lot. So maybe before we go through the next aliquot, could you share how do you approach painful joints? Oh, Ravi is.
Hi, sorry, folks. My internet is a little unstable. No, I thank you, Vale. Sorry. I would say that the approach is really exactly what Kirtan and Rama have emphasized. I think that deeper reflection, I will say, is that sometimes a painful joint is not actually a painful joint. More commonly, when people say that their knees hurt, it's prepatellar bursitis, or when their shoulders hurt, it's rotator cuff disease, or when their elbow hurts, it's olecranon bursitis. So proximal to the conversation that Kirtan and Ramla are having is the question, just because the patient reports that the joint is uncomfortable requires us to scrutinize whether it's actually a periarticular structure. If we arrive at the joint, and nothing to add, if we move away towards a tendon or a bursa, then we might have to revisit the prioritization.
Love that. And I know that you shared recently an schema on shoulder pain, I believe, that include the periarticular causes. And I really enjoy that point, that we should not jump into thinking that this is articular and think about the periarticular causes that could be more common. So great, Sarah, you got us on a great start. Maybe you can give us a little bit more on the presentation.
Okay, so I'm currently in my pediatrics rotation, so the patient is a kid. It's 14 years old, female. No, it's a female, sorry. And can I say something about like the HPI, or should I just stop here?
Yes, maybe you can give us a little bit more on the
Okay.
HPI. Thank you.
The mom says the kid is constantly complaining about pain in the right knee for approximately 4 days, getting even worse today, affecting the right knee also.
Yes. Do you think this is a good place to stop?
Should I say a bit more? Just like to.
Yeah, I mean, I trust you. Whatever you think is best.
Okay, so the kid also says that she's feeling palpitations eventually, and I'm gonna stop here just like to. I think this is an important part too.
Okay, so we have a presentation that I feel quite I don't know, maybe not so comfortable with, like painful joints and palpitations. Not my my cup of tea every day, but definitely something that we could talk about and discuss. And as this is a 14-year-old, I think we are right on the field that Dhruv really enjoys. So we have our own MedSpeds expert on the chat and on the session today. Dhruv, I don't know if maybe you could share with us how the age of the patient influences the way we think of the case.
Oh boy. So in pediatrics, we typically think of, is the patient, we sort of stratify joint pains by age. So if the patient is not walking, we typically think, patient has, infection, malignancy, or non-accidental trauma until proven otherwise. If they're a little bit younger, or if a little bit older, like maybe young child to older childhood, we typically add in inflammatory processes like juvenile idiopathic arthritis or JIA, but still keep infection and malignancy in the differential as well. For this 14-year-old, we now have two sorts of dimensions that we can look at this. So this looks to me like, and Sarah, I just want to confirm, this pain's been going on for 14 days or 4?
for 14 days.
14. So this would be subacute. And if I remember correctly, you had said that it was worsening over the course of that time. So subacute worsening right knee pain and now feeling palpitations. So I would prioritize infection and autoimmunity I would prioritize infection and autoimmunity at the start to as things to go down. In terms of infections, in the US, we typically think about endocarditis that may result from a septic joint. But around the world, one of the big considerations that we have to think about is acute rheumatic fever. As for autoimmunity, JIA is still on the differential even at this age. Any of the subtypes we could think of, because they can, because in causing an inflammatory picture, the palpitations may just be a manifestation of sinus tachycardia that this patient might have. So we may also think about other infections like Lyme disease that can cause an arthritis and a and heart block. But I usually wouldn't see palpitations there. But yeah, those are my thoughts right now. And I would definitely like to see more info about where this patient is coming from, what exposure she's had, and a little bit of physical exam before I can even be comfortable with trimming down my differential diagnosis on this patient.
Thank you so much. There's definitely something to take into consideration. I feel like I will definitely panic when seeing a patient on an age that is not so common to see, at least from my experience, and getting your perspective really enriches the discussion. And I was also seeing on the chat, please share your thoughts on the heart joint Venn diagram that we're having in the HPI. As far as we know right now, Dhruv made a really good point that this could not necessarily be a heart problem, but just like a sinus tachycardia that is manifesting as palpitations, but we really never know. So if you have any other points on this Venn diagram, please share them on chat and we will highlight them. I see Kirtan sharing his causes of heart and joints. So maybe Kirtan, you could share with us what you were mentioning on the chat.
Yes, first of all, I just want to briefly say that today we have a small group. So, I feel more comfortable because whenever we have more group, you feel shy and you are tend to make mistakes. So today we are small group, so I am feeling more comfortable. And yeah, so as the Dr. Kasoji and Dhruv alluded to, that acute rheumatic fever is something we have to be vigilant about. And if I remember correctly, one of the first cases which I saw from NHM, in that the final diagnosis was systemic juvenile idiopathic arthritis, which Dhruv alluded to. And in the differential, they had beautifully mentioned that how JIA and ARF, that is acute rheumatic fever, are so close, because if you look at them, both of them will present with elevated ESR and elevated CRP. Both of them can present with rash, although the type of rash is different, but still both of them can present with rash, both of them can present with joint pain. And sometimes we even tend to get pleural effusion, synovitis, and pericardial effusions in both of them. So both of them are very close entities. So juvenile idiopathic arthritis, acute rheumatic fever are top on our differentials because the patient is a kid. And apart from that, then we can move to other rare diagnosis, like is it a first manifestation of systemic lupus erythematosus? And furthermore, past medical history, probably the blood findings will guide us at how we can move further. And patient is a little bit older for Kawasaki's disease. If the patient had been around 10 years of age or maybe 5 years of age, then even Kawasaki disease can mimic this ARF and GIA thing. But as of now, I agree with Dhruv that we have to prioritize the GIA and ARF.
Thank you so much, Kirtan, as always. Amazing to hear from you. And I wanted to ask people in the audience that are from Brazil. I don't know if Sarah, this patient is from Brazil, so because you saw it. So maybe you could share, people in the chat can share what pathogens you think when you think about Brazil or the north of Brazil. So maybe Sarah, you could give us a little bit more on the past medical history.
Something that I think is still important it's that the mom said that the pain started in one knee, then went to another, and then the kid was also starting to feel pain in the, how can I say that? I forgot. Like in the upper side of the body, like in the upper side of the body joints. I forgot the name.
Like on the elbows, the shoulders?
The elbows, yeah, sorry.
Okay, perfect, perfect. Maybe you could give us a little bit more, or I don't know if you think this is a good place to stop, or maybe you could give us the southwest corner, as we call it, on the whiteboard.
Yeah, actually, from the past medical story, let me see that. From hospitalization story, the kid had to be hospitalized at age 16 because of pneumonia. And the mom says that the kid had a flu 2 weeks ago, especially complaining about sore throat and pain when swallowing.
Okay. So this is a good place to stop, or you want to give a little bit more?
I think, honestly, when I saw the mom saying this, it gave me I honestly thought about something when I first heard the story, and when the mom said this, I was actually a bit worried. So I think this is important too.
Great, I totally agree. A great point to reflect. And before we go to highlight the comments from the chat, I wanted to ask you, Rafa made a great point, and it is that we have a global audience always, but today especially. And so how do you say shoulder or elbow, or even like joint on Portuguese?
I know that elbow is cotovelo, and how I can forget stuff in Portuguese too. Ombro, like elbow is ombro. Yeah. Sorry.
Great. In Spanish, it's the same. Hombro as well means shoulder. So great. Yeah, I think this is a great place to stop with that past medical history, and also the fact that the mom mentioned that the pain has been alternating between knees and also in the upper body joints. What are you thinking, chat? Okay. Tiago, you were mentioning your hypothesis. Maybe you could share it with everyone on the audience. What are you thinking?
Sure. So I don't feel comfortable when we're discussing like adolescents, but every time I hear throat pain or flu-like symptoms, and then followed by what can be a polyarthritis in a country like Brazil, acute rheumatic fever for sure comes to mind. So again, I'm not aware of the situation. I don't see patients like this one, but in a country like ours, especially in places where people don't have access to medical attention, it's something to keep in mind, because for acute rheumatic fever is a complication of a strep sore throat that can be preventable by using antibiotics. So it's not common in places where you have medical attention, but here it's something to keep in mind.
Yeah, definitely with that. I think also rheumatic fever is a great point to kind of collect or complete our Venn diagram of heart plus joints. And I was seeing that also Nailayan was making a point for diphtheria, which is something that really surprises me, but I think, of course, it's a never misdiagnosis, especially in countries like Brazil. And here in Peru, we also had an outbreak quite recently. So maybe you can share with you, Nalayan, what you were thinking, why diphtheria, and yeah, what are your thoughts?
I have so on. So I thought and if there is unimmunized, so I'm curious about the history. Such as image, so throat like picture, and can
Diane?
so that most patients are cardiac invasion. And can cause it can cause arthritis.
And then I am so sorry. I think your audio was a little broken there. We couldn't really listen to what you shared. Maybe, I don't know if you had your camera on when you were talking. Maybe you can turn it off or I mean, you could definitely maybe type it in the chat and I will make sure to highlight what you were saying. As always, you have really great contributions to the discussion. It's always a joy to hear you. So yeah, I know there must be bad weather. Okay. So yeah, I think we can all agree that we are thinking maybe something infectious or like post-infectious polyarticular presentation here. And definitely rheumatic fever is something, as Diego pointed out, that we should keep in mind. So, and yeah, well, diphtheria as well. And also, I really like diphtheria because it could also affect the heart, like can cause myocarditis. I mean, I think maybe it will be more acute than this, just because myocarditis will probably be fatal on a patient that has a diphtheria type picture and not so, seems so, like not that remarkable of a flu symptom on a diphtheria presentation. So, and I see AMK sharing her thoughts in the chat. And Marie, maybe you could share with everyone, what are you thinking for migratory joint pain?
Yeah, just thinking about how kind of the characteristic of the joint pain can help with the differential. And when I hear something is migratory, going to different joints, some of the things I think about are, of course, we talked about rheumatic fever here, but also about gonorrhea. It can go to different joints, other certain like viral causes. Sometimes it can be additive, but sometimes it can go to different joints, Lyme disease, SLE, and then like leukemia as well. So just kind of keeping the differential broad, even though it certainly sounds like we have clues for a certain etiology.
Yeah, I love that point. We shouldn't anchor early on the story. And I mean, I think if we suspected rheumatic fever in every pediatric patient that has a flu, maybe that would not be so good. So I love that point, Anne-Marie. Thank you so much for sharing. Sarah, maybe we could get going with the physical exam.
So from the physical exam, the patient was in regular general condition. She had a fever of 102 Fahrenheit or 39 Celsius. The cardiac frequency was of 124, and the respiratory frequency was of 30. There are edema in the knees and in the elbows, and they were very hot and swollen, and there was a lymph node in the cervical region.
And was there something, or I don't know if maybe you're saving it for the less adequate, the next adequate, sorry, but was there anything on the cardiovascular exam?
Yeah.
As we were worrying?
It was actually, the heartbeat was rhythm and normophonetic, but there was a systolic murmur in the mitral focus of 3 of 6.
Okay, this has definitely been really helpful, Sarah. Thank you so much for presenting this case, and you're doing it really wonderful, really systematic, and making us kind of get up. You know exactly where to pause so that we can have a really rich discussion. So thank you for that. So Chad, what are you thinking with these findings on the physical exam? We have a lymph node, we have some vitals that are not quite normal, and we have edema in knees and elbows. And I believe you also mentioned erythema and that the joints were hot. Okay. So Rafa, I love that one word can say a lot of things, and you definitely encompass that, Rafa, with what you were sharing in the chat. Maybe you could open your mic and thinking or share what are you thinking. I know that this is like a really good step one pearl. So what are you thinking, friend?
Yeah, so I think acute rheumatic fever becomes our priority, even though we don't have to anchor the diagnosis, because we have like this sore throat that the patient had, and then eventually having knee pain that is now migrating to other big joints as well. So maybe this patient actually didn't have like a viral infection as the primary care physician supposed to in the beginning, and didn't treat the patients, but actually this patient was having like sore throat due to strep pneumo. And then we saw we can think about Jones criteria, right? Because we can think about the joints being affected, the heart. We can see actually epicarditis in these patients, but we don't know that exactly from the physical exam. What do we know is this patient has like mitral regurgitation, which is something compatible with acute rheumatic fever. I always remember this mnemonic mat. First, the mitral valve, then the aortic valve, and then the tricuspid valve are affected. There this sequence of events. And then also I think about the subcontinuous nodules and the erythema nodosum, and then the pseudohome chorea that this patient can have as well in the future.
Thank you, Rafa. Amazing recap. And I also see someone new on the chat. I don't know if you've maybe joined us before, Kevin, but I would love to hear from you. Where are you from, and what are your thoughts on the case? If you can, of course.
Well, I was just put on the spot. Yeah, I've been lurking for a bit, for like about a year maybe. I'm a 5th-year medical student from Guatemala, born and raised. Currently in my dedicated for the step 1. And yeah, I agree with what you guys have been saying. Definitely sounds like rheumatic fever. If I'm not wrong, mitral regurgitation is usually like early stage rheumatic fever, which is kind of like what it sounds like. And I definitely think of the Jones criteria, like Rafa said, you know. And yeah.
Thank you so much, Kevin, and really great to have you here. We have a lot of people from Guatemala, Maria and Felipe, that are always around, so really great to hear from you. I don't know if maybe before we go to the next aliquot, you could share something from Guatemala. I know that you have a very diverse, and I must say that I love Guatemala because of their volcanoes. I am dying to go and do a hike on a volcano, so maybe you can share something from your country.
Let's see. There's actually a volcano that has a lake at the top on the crater that you can go to, which is super cool, called Ipala. If you're ever there, it's like a 45-minute hike up, and it's super cool. And yeah, there's like 50 volcanoes. I actually don't know the number, 40 something, and it's actually pretty cool. Yeah.
Amazing. Definitely expect me there, and because I love hiking, and definitely we'll go there, visit Maria hopefully soon, and we can meet up Kevin as well and go hike to a volcano. So really great discussion on the chat. Thank you so much, Kevin, for sharing your thoughts, and also for opening your camera. Really appreciate it. So Sarah, maybe we can go on and you could share with us some of the exams.
So for the exams, I don't have the exact numbers of the blood count, but I do know that the patient had leukocytosis. We also did FAN. I don't know if this is the exact name of the exam in English, but it's the exam for lupus, and it came negative. We did a CRP, and it came very high of 55, and an ASO of 500. Oh, and also after that, we did an electrocardiogram that showed a prolongation of the PR interval.
Great. Thank you so much, Sarah. So chat team, what are we thinking with these new findings? A prolongation of the PR and some interesting autoimmune or well inflammatory panel that Sarah had just shared with us. So I see a familiar name on the chat, and I would love to hear from her because I know that she was a discussant not so long ago. We love to, I believe it was in Neuro VMR, Ana Carolina. I don't know if maybe you could open your mic, share some of your thoughts with these new findings, and tell us a little bit more also where you're from. And yeah. Oh, I don't know, Anna, you could open your mic. It's okay if you can't. We totally understand. Okay, maybe Anna can't. That's totally great. You should definitely check out, I believe it was 2 weeks ago that she discussed on her VMR, really great discussion. So we were thinking about a prolonged PR interval, and I see some thoughts on the chat about what this could be. Oh, I love that Pearl, Tiago, about the PR interval. Could you share it with everyone on the audience, please?
Yeah, sure. So I don't know a lot about it, but I could remember it's a classic sign. And then I just Googled right now, and I found that despite it being classic, it was presenting 20% of the patients at the beginning, at least in one study that I shared here on the chat. And I don't know the reason, if anyone knows the reason that we expect this PR alteration, just share here because I'm curious about it.
Yeah, I think that's a great point. I feel like I always remember the major criteria, as Rafa mentioned, the Jones criteria, but I really don't have on top of my mind the minor criteria, that is a PR interval included. And Kirtan, I think, has an answer for you, Tiago, about why does it happen.
Yes, so please correct me if I'm wrong, but as far as I remember, one of the things that we learned in pathology was that these streptococcal organisms have lots of, M proteins, characteristic proteins in their surface, cell wall and cell membrane, and those M proteins have molecular mimicry to various of cardiac antigens. So once we have that infection, our body starts producing antibodies against them, and those antibodies can eventually hit the heart, and that's why we get this carditis. In fact, this specificity is so much that only certain serotypes of streptococcal infections which have particular M type of, like let's say M5, M6, M11, there is lots of terminology there, but only particular M type of organisms can cause it. And along a similar line of thinking, only certain types of M can cause post-streptococcal glomerulonephritis. So we have nephritogenic strains of streptococci, and then we have cardiogenic strains of streptococci. So following certain source of infection, you will get PSGM, and following certain source of infection, you will get ARF and carditis. So it's very intriguing that how a same organism and same sort of M proteins can cause different organ damage, sometimes kidney and sometimes heart.
Thank you so much, Kirtan. I mean, you're an expert on all autoimmune and all antibodies, so thank you for sharing. And I think, I wanted to give a shout out for everyone to please share your problem representation in Spanish or Portuguese or in any other language that you speak. We will make sure to highlight it on the whiteboard. So please share it. It doesn't have to be super big. I mean, the idea is that it's short, brief, and please do. And I think maybe, Sarah, I don't know if we're getting close to the final diagnosis or maybe we can have more aliquots.
Actually, since we were in a smaller hospital, we couldn't do any more exams. So we did a final diagnosis and we just sent the kid for another hospital to do much more exams. But it ended up being acute rheumatic fever. So everyone was right, explaining the Jones criteria. And something that it's interesting is in the same hospital that we attend this kid, we also had another kid treating actually an carotid aneurysm, if I'm not mistaken, also because of acute rheumatic fever. So it's something that it's very common in Brazil, unfortunately, because it could be treated. It could be like when the kid had the first infection, it could be treated, but it's something that, especially in my part of the country, I guess, it's something that is still very relevant.
Thank you for sharing that point, Sarah. I think an amazing case, and the way you presented it was really wonderful, really concise, adequate, that allowed a really rich discussion. And thank you, Chad, for sharing your thoughts. I love the point that sometimes we, or a late diagnosis and not treatment when this patient had a flu could have made a difference. We should definitely advocate for more resources and early diagnosis and earlier treatment for all our patients. So thank you so much for sharing this case. And I feel like strep has a lot of complications that are really, really rich. Wanted to reflect a little bit on that. Like we have neuro complications, and we have seen in past cases on neuro VMR, like pandas, that is a very new diagnosis, but I have seen a lot of cases reports recently, and also the classic Sydenham chorea. And then we have stuff affecting the kidneys, and now something affecting the heart. Definitely a fascinating microorganism. So thank you so much for sharing with us, Sarah. Really appreciate it. And please go on and continue sharing your problem representations in our languages, because we would love to hear you. Or maybe, I don't know if someone that is from Brazil or speaks Portuguese could maybe read the problem representation that our scribers have put on the whiteboard. I don't know if maybe you, Sarah, to just close us the case.
So for, let me see. So in Portuguese, it would be, should I read it? Let me see. It's é uma menina de 14 anos que se queixa de dor no joelho direito por 14 dias e também tem reclamado de algumas palpitações esporádicas. E a mãe também diz que a dor ela tem se alternado entre o joelho esquerdo e direito e também dor nos ombros e cotovelos.
Muito obrigada, Sarah. And that's about all you're going to hear from me in Portuguese. But thank you so much for sharing this case. And thank you so much, everyone on the audience, for sharing your thoughts. Really, really great discussion today. And maybe we can pass the mic to Gabby, who always has amazing teaching points, and today is also doing them. So really excited to hear from you.
Yeah, so thank you everyone for the discussion, and thank you, Sarah, for the case, and Vale, you did amazing as always by facilitating the Global VMR. So I think the first pearl that I got from this case was that what Rabbi shared with us, which is that a painful joint is not always a painful joint. So we have to look for other causes of periarticular disease, such as bursitis or tendinitis. And when regarding painful joints, we have to try to see if it's arthralgia or arthritis. We have to definitely rule out septic arthritis because it's a very severe diagnosis, and clues for that are in fever, systemic illness, and redness in the joint. We have also to define the complaint. For example, check the time course. What are the joints that are hurting? If there is migration, distal versus proximal disease, symmetry, prior history of similar conditions, and also who is the patient. is it a young patient, old patient, and this is going to help us to define the etiologies. Drew also shared with us that in a pediatric patient, we have to think first of infections and malignancies, but also inflammatory causes like idiopathic juvenile arthritis. And we have, in this case, we had heart and joint symptoms, and we made a small list of diseases that can cause pain in or symptoms in those places, which are endocarditis from septic joint, acute rheumatic fever, Lyme disease, and systemic lupus erythematosus. Also, we had a lot of other causes for migratory joint pain, which are gonorrhea, viral infections, also SLE and leukemia. And regarding acute rheumatic fever, which was the final diagnosis, have taught us about the MAT mnemonic, which is the role of what are the valves that are injured by this disease, which are mitral valve, aortic valve, and tricuspid valve. And we also have the major and minor criteria for rheumatic fever. The major criteria are the Jones criteria, which stands for joints, heart, nodules, erythema marginatum, and cytokine. And the minor criteria stands for PEACE, which means previous rheumatic fever, ECG with PR prolongation, which this patient had, arthralgias, CRP and ES are elevated, and also elevated temperature. And also Thiago shared with us an article showing that actually PR interval prolongation can be present in around 20% of patients with a rheumatic fever. I think that's it. Thank you all for coming today. I really enjoyed today's case and discussion.
Thank you, Gabby. I wanted to take a minute to reflect on your amazing teaching points. I love the emojis. I think that's a great addition. Thank you so much. I love it. And please join Elabora Medicina, which is the podcast that our Brazilian friends have on clinical reasoning. I really, really enjoy it and cannot recommend it enough. So please join them. See you all tomorrow.
Bye.